comparable to what I've seen as a phenomenon among helpers, which is if you're not feeling like you're effective, you often you will do one of two things. You'll either be disparaging of your own work and what kind of job you do yourself, say that you are burnt out, say that you're done, or you might blame the patient. And I think that in substance use treatment, we tend to fall into that a lot more, simply because it is an emotional roller coaster for all of us to work with people that use substances. It's an emotional roller coaster for them as well. And so when I first got to the clinic where I work, I think that I saw some of that phenomenon. There was disparaging of clients. There was saying, well, you know, this is all we can do. And I think that that kind of mentality tends to be less helpful. So being able to look at it from a place of detached emotion, not being attached to the outcome, for you yourself to be able to prevent burnout. And by detachment, I don't mean not being compassionate, but I do mean not being codependent. And what I also found was helpful was being able to constantly reassess what is our program doing, what can we do better, what other perspectives can we take in order to improve. And so we started looking at various ways that the clinic practiced things and started to improve the chances of a client being able to recover. I think that, first of all, we understand that it should be multi-pronged. We should offer many choices, not just one. And so we developed a system in which we provide ample choices, especially in early recovery, to be able to provide clients with what fits for them and what fits for their stage in recovery. Oftentimes, this is not the first time someone has come in to receive treatment for their recovery. And so they bring with them skills and experience as well. So we developed a system which provides skills classes, and that's what I'm here to talk about today, psychoeducational skills classes. Our old clinic model and culture was that clients were failing in treatment. We would hold up our hands and say, well, that's just what they do sometimes. And really, I think that it's much more helpful to be able to look at what else we can do. There was a negative treatment relationship. We would again have that experience, and then being able to in treatment, many of our clients seemed to stay forever. Some of them improved, but there was no real talk about discharge unless someone was using substances that were unsafe. We had a one-size-fits-all kind of treatment. Well, this is the way we do things. And we expected people to fall in line with that, and that didn't necessarily help. We had also practitioners that tended to practice more like individual therapists rather than have a uniformity across all of our counselors and social workers to be able to provide a uniform kind of treatment style. And we had sort of amorphous treatment expectations. And that means that when the client would come in for treatment, they certainly had their own expectations. We had our own, but we didn't necessarily make it clear what they could expect in therapy. And so my question is, if a client does not know the rationale for the treatment that they're going to receive, how can they offer and sign for informed consent? So you can see that we had a dilemma at the clinic. It's been 2 years or more since we've implemented the changes, and so I can talk a little bit more about how they've affected the work. Let's see, the skills classes that we've implemented have been in play for about 3 months, so I can tell you how that's working as well. So here is sort of where we started. We wanted to be able to offer clients many choices specific to whatever their treatment needs were. So if, say, they were in a domestic violence relationship, they had a traumatic childhood, and they also had a condition of anxiety or PTSD, us being able to treat each one of those conditions in an episode of care. And that episodes of care can happen concurrently for those 3 different conditions. So we can have multiple episodes of care happening at one time. So how are they developed? Well, we collaborate with the patient and the provider, right, to be able to, or the treatment team, to be able to identify what the conditions are, to be able to determine what we're going to do with that, what kind of intervention we're going to choose. And that can first be a skills class and then later a group or an individual treatment. We can determine what we want to change the most. So oftentimes, for example, if someone has an anxiety condition, they say going to the grocery store, going to a crowded place is incredibly activating, then we want to be able to target going to the grocery store, right? We want to be able to increase their functioning. Be able to go to the grocery store without feeling as anxious is certainly something that we would want to target. We define the duration, the frequency, the intensity of the treatment. So you can see it's a lot more specific than maybe what people might have assessed and practiced in the past. And then in consideration of the remission period. So after we've provided this treatment, we want to give a length of time to where we are not providing that treatment anymore, but we are seeing how effective it was and how it continues to be, and then reassess. And the remission period of time is post-treatment in which no symptoms of the condition are present. So we want to monitor that. We sort of, especially for addiction, we want to say it's about 2 years post-treatment before we consider discharge. But there's certainly exceptions where we've discharged almost immediately after they've finished treatment. For chronic conditions, it's recommended that remission period is about 1 to 2 years. So types of groups in early recovery. I wanted to talk a little bit about why we selected psychoeducational and skills groups. And I'm going to call them psychoeducational skills groups, essentially the combination. We've chosen to combine the first 2. But in SAMHSA, they recommend that in early recovery, that these groups are available to people. So having not only psychoeducational and skills groups, but psychotherapy, cognitive behavioral support groups, and task-based or specialized groups are available in early recovery. What the research is pointing to as most effective for people in early recovery of addictions and substance use tends to be manualized and skill-based. That teaching skills such as relapse prevention and harm reduction, along with providing manualized interventions, tends to be the most effective. Now, that may be counter to quite a bit of what you may practice in your current practice, so I'm happy to answer questions. Clients in early recovery, usually we see them, they are seeking treatment. They are usually receptive. They have some degree of insight about their behavior that has brought them to find us. They're interested in changing behaviors which are not working. They're enthusiastic and optimistic about the future. They may be in dire straits. Their behavior may negatively have affected relationships, employment, education. Their functioning is very affected by what they've done and what they continue to do. And they may have vague expectations about what it may mean to have therapy and treatment. Oftentimes, if they haven't received treatment before, they picture what they may have seen in movies or on TV. about what therapy may be. So tell me about your mother. Or in treatment that they may expect us to see them every day, that they may be admitted inpatient. We're an outpatient facility. So we have to be very clear about what they can expect, because certainly they come with their own expectations that may or may not be realistic. But clients in recovery, in early recovery, are also living in unsafe, unstable environments. Even if their environment is fairly objectively safe, they may feel unsafe. They have a natural ambivalence about stopping use and continuing to use. They may lack positive social support or relationships. They may be strained because of their compulsion to use. They may lack self-esteem, a sense of competency. They may feel depression. They have negative mood, negative cognitions about what they continue to do. They're lacking in income or job readiness at times. They may be lacking transportation. They may be experiencing a cascade of adverse events, which may have just happened or may continue to happen in early recovery. They're experiencing health and mental health symptoms, experiencing severe anxiety about change, experiencing withdrawal, adjusting to possible medication-assisted therapy, which is also what we provide at ASAP. We provide both Suboxone or Methadone or Vivitrol. And they may be continuing to use. They may have skills deficits. In fact, that's what we find is the most common, and that's why we shoot for people in early recovery, being able to provide them with more skills classes. They may be feeling an intense amount of guilt or shame around their use. So due to these factors, clients tend to vary as far as how they respond, but there are times when clients will come into that first session and share everything all at once and then never come back. Or come back, but really try to avoid therapy after that. They may feel with their expectations about therapy that they do need to share everything right away, and they don't. I think being able to help them through a structure to prevent that kind of dynamic can help. The alternative sometimes that I've experienced is they may not feel comfortable sharing anything at all, or they may not want to share key information that might beginning to guide their behavior, to also limit the amount that they share, but also prepare them for that point in which they do share and prepare them for treatment and therapy. And to make exceptions in a case-by-case basis. I can't emphasize this enough. I think every single patient will have different needs. Being able to meet them and get to know them over time, to be able to adjust those treatment interventions is probably what's going to make you most effective. One size does not fit all. There are many people who will live in a way that may indicate that they need some case-by-case exceptions as treatment resistant or avoidant. In fact, I think it's much more about being able to negotiate at that point, being able to both look at what your expectations are and what their expectations are, and being able to adjust accordingly. Some people are ready to dive right in and truly have been to treatment several times, have been in therapy as children, what have you, and may be familiar with the format and are able to engage in therapy almost right away. Others, it may take years to be able to build skills, to be able to build trust, to be able to establish safety. Maslow's hierarchy of needs comes into play here, I think. You cannot possibly expect someone to engage when they, in fact, are struggling with their basic needs. It's our job to empower the client to be self-directed in her treatment or his treatment. I think it's very important, especially at that very early stage, not to disempower. And I want you to take a look at your program and look in the ways in which you may inadvertently contribute to that. What your program may do. Certainly we had things that we needed to look at as far as how, in fact, we did that. And there definitely were ways. There's still some ways, in fact, that I think that at this point we may or may not be able to adjust. But I think that we've come a long way. I see that a lot of people now in our programs are not waiting to hear word from their therapist as to what to do next. They are taking initiative themselves. And I think that's really important. That's the way you assess it. If people are feeling disempowered, they often will complain, be sarcastic, be avoidant of treatment. Certainly empowerment can help that and be the panacea. It's important to both limit oversharing at initial engagement and put forth clear expectations for treatment for people that have a hard time feeling safe as well. Just being able to say, we're here, we're going to create a safe space in which you can share, but also you have to know that we're not expecting you to share until you feel ready. And provide a regular, non-judgmental kind of check-in to be able to assess the current treatment goals, where the client is now. So I think that treatment goals need to be very specific, need to be time limited. They definitely need to be SMART goals. And so I just want to get clean. When you've got someone who's using heroin daily over 4 to 8 times is not a reasonable goal. Break it down. Just talk about the next 2 steps, maybe using less, maybe using only at certain times. Being able to make them reasonable goals, I think, is very important. And having that conversation, making that a regular part of the discussion, but also just, how are you doing? Is there anything resource-wise that you need? In early recovery, it's important to be able to create that dialogue. They themselves may not be able to immediately identify what they may need. So general question like, how can I help you, is not going to be very helpful. Being able to even structure your questions to where you have an idea of how they get to and from the clinic each day. If you have an idea of what they had for breakfast, being specific, getting specifics, but also being able to do the dance, of course, of being able to be respectful of their privacy if they're not comfortable in sharing. Creating that dialogue, but also perpetuating that trust and constantly demonstrating that. So we based our changes in our clinic on this trauma-informed model by Herman. The first stage is being able to establish safety and stability. We cannot possibly expect people to go into deep therapy when they are feeling unsafe, as I've said. And so what we suggest is being able to go to on acceptance and commitment therapy, just being able to learn how to be present, how to manage distress, dialectical behavioral skills. These are the kinds of groups that we suggest. Group exposure, I think, is very important at this stage as well. I think that people oftentimes feel that they are the only one who experiences the things that they do. And in fact, being able to have that camaraderie, being able to see that other people have some of those same experiences, some of those same perspectives, is really empowering. And it's also oftentimes our population are victims of trauma. In fact, I rarely meet someone who has had at least something traumatic happen. They may have a history of trauma. They may, in fact, not have PTSD, but either way, I think that people are extremely anxious about being around other people. And so it ends up being sort of a miniature exposure exercise to where they get more comfortable in being around some people that are not their old peers that they used to use with. The second stage, after they've gotten a sense of stability in their lives, being able to mourn, being able to grieve their trauma, being able to grieve the losses that they've experienced in their lives, perhaps the ones that they have, that they feel guilty, that they in fact have caused. Being able to do therapies that are intensive, such as PTSD treatment, like cognitive here under mourning and grief is PTSD 101. That's our group that we offer to be able to provide some coping skills around the common symptoms that people experience with PTSD prior to and in preparation of therapy. And then we use evidence-based therapies to be able to treat it, like CPT or PE. And we also, at this point, can provide interpersonal psychotherapy for depression, anxiety, CBT for grief, whatever it may be. Manualized therapies, I think, tend to be extremely helpful. They also tend to be very efficient and effective. Studies have shown that being able to at least integrate these into your practice are important. This is an opportunity that people can reestablish connections, be able to bloom and blossom as a person, being able to create more solid friendships, stronger connections with their families. So family and couples therapy is very effective at this point. Being able to have peer support groups at this point tends to be very helpful. Community support groups such as AA, NA, Smart Recovery, being able to reconnect, getting a job, being able to go back to school. And we have what's called aftercare groups. And I think that aftercare groups we're beginning to develop for seeking safety as well as for PTSD to be able to help. So that's essentially the model that we have. And I think that being able to think of therapy as a component in that treatment, but not the sole component, is important. Being able to establish safety and stability, of course, is also well supported by having them be able to go back to their doctors, address any health issues that they may be having, that they may have avoided or developed along the way. Being able to talk to case managers and get the resources that they may need to establish regular transportation to the clinic, safe housing, etc. Also, it will take coordinating with community services and working with other entities. So you can see also at the beginning, and I want you to think about Maslow's hierarchy of need in 2 or 3 stages for Maslow's pyramid is here as well. So psychoeducational skills is sort of the foundation on which then we can provide evidence-based psychotherapy. And then lastly, being able to provide peer support, outside peers, being able to start that near the end of the period in which they're receiving psychoeducational skills, all the way to the end with process or interpersonal dynamic therapy. I think it's very important for us to remember this as we approach people that are just beginning to start therapy and treatment. It should only be used at the end. Let's see. So as a foundation for their knowledge, we use the Herman model. It's, in a way, it's because the clients that we see have in some ways stopped developing about the time that they started using. They come to us often with a severe skills deficit that they may or may not be able to identify. And so our being able to provide those skills without judgment, without waiting for them to ask for it, without their identifying it, certainly can help at least enhance the toolbox that they already have. And due to these skills deficits, they may encounter adverse having a relationship, raising children, attending individual therapy can be particularly daunting or challenging for them. And so being able to establish a good foundation of skills actually helps them move on to be able to have that therapy. But by preparing them, we can empower as well. So what do our psychoeducational skills groups look like? Well, psychoeducational skills development groups always integrate prevention and educational strategies within a here and now framework. Staying in the present, I think, really helps as far as helping clients learn that skill themselves. So in fact, it's a little bit of mindfulness kind of tucked in there. We provide increased skills and functioning on all those group dynamics that any group will have, generating trust, noting conflict, giving feedback, developing norms, as well as providing skills through the facilitation of movement within the group, primarily in this case through homework. Psychoeducational skills can also be implemented at any stage, but are particularly helpful in early recovery. They support skills development in an equalizing environment. So those who want to share too much, those who want to share too little, those who have been in recovery many times versus those who are new to recovery. It is an equalizing environment, old, young, female, male, etc. Interactions or educators, there's no pressure on the group to establish things that they may not have the skills to do yet. And we provide a skills-focused education. Here are examples of the classes that we teach. We do about an hour for each one of these. We call it our Skills Academy. So you can see there's not only interpersonal health, but there's also general health, as well as communication, relapse prevention, and psychological health. So being able to emotionally regulate, being able to deal with stress, assertiveness skills, boundaries, all sorts of things are discussed within these skills classes. So in our clinic, we started dividing people fairly unstable. And so what we try to do with these classes is we encourage them not to use 2 hours before or 2 hours after the class so that they can create a sobriety window. This may be the first time in which they've not used for that period of time, but can attend the classes. And this also helps them use that skill in other settings and in other times. And that window can be expanded. So it's in and of itself a relapse prevention skill. We provide skills training, including basic, so I already listed those, health, life skills, distress tolerance. And we provide case management to boost stability and help with community resources. If people have outside providers, we try to form that a person's circle. They are not just an individual. We provide many and varied opportunities for participation. So we also encourage them to have the alternative of being able to check into, just have that kind of how is it going kind of conversation. What can we do to help? How was transportation? Did that medical funded transportation help? How did it work? Is there anything we can do to alter that, to be able to make it better for? And we provide support with any challenges that they may be encountering, because, as I said, and continue to go through adverse experiences. And then also, we continue to assess their progress. They continue to do that too, in that collaborative way that we develop the treatment plan. And then after that, as people demonstrate their stability, and we have that increased use of their skills, they're demonstrating that they're using their skills. They're attending more classes or more check-ins. Their acuity is decreased. Their mental health symptoms are decreasing somewhat. They may continue to be highly anxious. They may, in fact, be more anxious than when they first started recovering, because they may be using less. But that's something we can help them with in the second stage. If they're definitely voicing assess their goals, they discuss them, what they'd like to do next, and we certainly do a comprehensive assessment at that point to be able to figure out what interventions would be most effective, and we make those recommendations. Then we move them on to stage 2. This is the working stage where we can provide intensive therapy. We use manualized therapies, for the most part, being able to utilize and address the conditions that they came to be treated for. And I think that it tends to help with the effectiveness of the treatments. And then last, after, and this stage can last for B. So if they've got various conditions, we certainly use the episodes of care. We'll provide an episode of care for anxiety, one for depression, maybe one for grief, and then search for that stability. Search for that, reassess the remission period, and then move them on to stage 3, in which they become part of the clinic in other ways other than being a client. They become a peer, and they can lead groups. They can participate in helping people in early recovery. It's their maintenance phase, so it really solidifies their stage in recovery. So we really want to sort of give them that reinforcement that they're at a different stage now, and that they can certainly be of tremendous help. And that we, that they're, can I go back? And that they can also be involved in education and getting a job, being able to develop a career at this stage. Do you have any questions? I'm finished with my presentation.
Yeah, guys, now we're going to open it up to you all if you have any questions for Kate about her presentation. No.
Well, thank you everyone for joining.
I want to thank you, Kate, for giving us this presentation today. I know it's awkward right now with this whole transition phase, but thank you for joining us and thank you for taking the time to come and present for the group today.
Hello. Hi.
Brenda, awesome.
For your presentation and ask if you could talk a little bit more about using the PE and what's the other one? CPT.
Right. So PE and CPT, prolonged exposure and cognitive processing therapy, are approved by the American Psychological Association as being the most effective treatments for PTSD. Oftentimes as secondary to provide evidence-based, these are manualized therapies that both last about 3 months. They're about 12 sessions. One of them starts, you can look them up. I recommend looking on YouTube and search for whiteboard videos by the VA. And you can type in prolonged exposure and get information about that. It's a nice, neat explanation. And you can also search for cognitive processing therapy. And also, they've got some videos about trauma in general that I think are very informative. I've used them quite often with my clients for helping them sort of have that validating effect. A lot of the time, they've been misdiagnosed all this. Sometimes it's bipolar or it's borderline, all sorts of diagnoses that really are not as relevant as the cluster of symptoms that people may have with PTSD, specifically anxiety, depression, self-defeating behaviors, negative beliefs about themselves and the world, etc., right? And a lot of the time they'll be diagnosed with maybe an anxiety condition or depression generally, but some pretty severe ones I've seen as well. But being able to stabilize them in treatment, provide the PTSD 101 skills group that has the coping around PTSD symptoms, and then starting either CPT or PE is important. Prolonged exposure therapy kind of starts with the actions and then changes thoughts. And then changes the actions. Prolonged exposure therapy is, we tend to see recovery. Honestly, both of these produce a really exciting effect that has lasted over time. They've done longitudinal studies about the effectiveness of this. Like regular therapy, they followed people after they've stopped therapy, and 18 months later, of course, there's very little effect that has still lasted. Whereas cognitive processing therapy or prolonged exposure therapy, they followed people even after 10 years, and they're still utilizing those skills. They are still applying them to their lives. They have very little symptom very little symptom return. So their anxiety is significantly reduced, their depression to have learned both of those. The VA does provide that training to its psychologists, and fortunately, one of the psychologists came over to ASAP, and I've learned it from her. But they are manualized, and they are available through the VA. Let's see, the prolonged exposure therapy, you can buy the book. I know that cognitive processing therapy as well, there is a book out there, so you can search Amazon for either one of those, be able to learn them and implement them in your own therapy practice.
Thank you very much. That was very informative.
You bet.
Does anyone else have any questions for Kate before we wrap up here?
People can also chat their questions in the chat box if your audio isn't working for some reason. We're happy to answer that way too. Okay.
No.
That wraps it up for the day.
All right. Well, thank you so much for the presentation again. I do have some announcement for you guys before we wrap up here. I wanted to remind you guys that for the remainder of June, the ECHO CMEs will be offered through private email. CMEs will be provided by our home team here at CBH, and we'll explain the whole process with that. And it shouldn't be a huge transition for you guys, but you'll just be receiving them differently. And also, our session times have changed starting in July. We are trying to figure out a better time for more participants and kind of get a better retention rate with our counselor series. So we're going to be chopping it down to just an hour starting from 11 to 12, but that's going to start in July. So for the next two sessions coming up in June, it'll still be from 10 to 12, but we're going to try to give it a go from 11 to 12 starting in July. And like I said, you'll be receiving a slew of information throughout the next couple of weeks of this whole transition period and how things will look starting. Our session, the topic is who's your team, working with community health workers, nurses, and medical providers using an integrated approach. Hannah, do you have anything to add?
Yeah, so we are going to do a schedule for case presentations starting really in July. And that schedule we have today to put together with everyone who wants to go ahead and volunteer a week that they want to present. I am concerned that this might be difficult to do right now. A lot of people have chatted that the audio connection is not good today. So we can try this, and if it's difficult to get it organized, we can work on it the next time we all see each other. If you can hear me, will you send a chat right now if there's been any breakup in what I've been saying? Anna, can you hear me okay? And Tristan, I'm trying to think. Brenda, I know you've chatted.
Can you hear me now? This is Anna.
Yeah, can you hear me okay, Anna?
You know what? At times, for some reason or another, I couldn't even connect. It took me a long time to be able to connect even to the Zoom. Mm-hmm. But it's like, you know what, then you guys will get muffled and I can't hear. I can see your mouth moving, but I can't hear what's going on. So I missed a lot of the case. Your presentation, your presentation that you gave earlier, I missed a lot of that and then the calls kept dropping and stuff. So for some reason, and it could be on my part too, where I'm located.
Had a couple of people say that the audio was a little difficult today. So it was probably, I'm guessing we have a lot of people using our broadband right now at our office. So it's probably has something to do with that. So yeah, let's give it a go and see if we can organize this schedule today. So really the purpose of doing a schedule is that we don't all have to kind of sit at the end of the clinic and be like, who wants to present next week? But rather just to have some more organization around this and to help people who might want to present but feel uncomfortable volunteering, have a little bit of more prep time instead of feeling put on the spot to do a presentation. So I'm going to share my screen today, and you guys can see what the schedule looks like. And if people can I know we have a few people joining by phone, so I can email the schedule too, and people can volunteer that way.